in terms of the biggest thing that we've been facing over the last few months has been COVID, and particularly for cancer patients and COVID at this time, and for oncologists as well. It's been a really difficult time simply because you're weighing up constantly the risk of death from your patients anyway from their cancer, and then giving them potentially, well, immunosuppressive treatment that may potentially shorten their life if they do get COVID. And then you're also looking at whether they get COVID, if they are immunosuppressed, and whether that's going to be a more severe form of COVID than other people, and kind of instinctively you would feel it would be. And then also talking about the risk of delay to treatment. And that's a very difficult discussion, both for the patient, but I think not to minimize the effect that it has on us as oncologists as well, because at the end of the day, you potentially are talking to somebody your own age about delaying their treatment, and that it may not, as a result, be curative, or it may shorten their life. And that's a very difficult emotional discussion. And I think there has been so much about how difficult it has been for the patients for the last few months. And I would never denigrate that. But I think it's really important to note that it's been a very difficult time, particularly as oncologists, for the last 4 or 5 months. Now, the data that I'm going to talk about today is very limited, and it's obviously now being looked at with the retrospectoscope. Whilst when COVID kicked off, we had no data, and we were a lot of the time with managing our oncology patients, it was purely chatting to colleagues in Italy and in Spain and seeing what they were doing, and trying and failing in certain circumstances just to try and see if we could do the right thing. And the problem with COVID is that COVID happens really asymmetrically. So even within a cancer cohort, it's not going to affect all cancers the same. Some cancer types are more at risk than others. And I suppose the key point, and particularly the key point for anyone coming back and worrying about looking after COVID patients or anything, is none of us really know what we're doing, and we're all kind of learning as we go along. And that's been, I suppose, one of the, I hate to use the word silver lining out of COVID, but it has made us realize that as doctors, we don't know everything, and even people who did think they knew everything don't know everything. So it's been a very good learning experience in terms of knowing our limitations and actually realizing that we're all learning at whatever level you are at in your training. Now, just talking through briefly what we're seeing practically on the wards. So St. George's is a bit of a hub in Southwest London. So we've had over 1,000 patients in with COVID in the last 3.5 months, with a mortality of about 35%. So our views are slightly coloured. My views are slightly coloured. Some of us went back and did COVID through some of our choice, some of our not choice. We were co-opted onto the the medical mega teams. So started looking after general medical patients, and I certainly haven't been a med reg for about 12 years before that. So it's been interesting, to say the least. In terms of the clinical features of COVID that we're seeing and that we'll all know about, fever, dry cough, shortness of breath, myalgia, headaches, and now it's now accepted that the change to taste and smell is a feature, which we were seeing early doors anyway. And again, there's a very clear COVID rash. Now, it was published yesterday, a brilliant picture in the AAC or in a lecture, but there's a very clear kind of maculopapular COVID rash, particularly on fingers and toes, that it looks a little bit like chilblains sometimes. And that is actually present in a lot more people than we initially thought. Now, in terms of investigations and management of COVID, it does feel a little bit, and I don't say this flippantly, it feels a little bit like veterinary medicine, simply because there isn't a huge amount we can do on the wards practically. Yes, checking the bloods and doing the CRP full blood count, but actually not, your CRP and white cell count isn't always raised, and that isn't actually a clear indicator whether it's COVID or not. The biggest thing is lymphopenia, but as we know, in our patients particularly, lymphopenia is not unusual. But in general medical patients, and if we are going into round 2 of COVID and you're going to be co-opted looking after some COVID patients that may not have cancer, lymphopenia is present in over 80% of patients. And what you will often see is, as they start to recover from their COVID, or they're starting to go out, if they do have a raised CRP, you'll see a slight crossover. So your CRP will be coming down, and just as that comes down, your lymphocytes come up probably about day 4, and that's often a sign that they're on the road to recovery. Now, again, chest X-ray, we do it, and actually at the start we weren't even doing it because we couldn't get portals on the wards, and we couldn't send patients down, so we were just totally going clinically. Chest X-rays can be normal, and even in patients who have had positive swabs and everything, their chest X-rays and CTs can be normal, and patients with, patients, what we're finding now is patients coming in with trauma calls or anything like that are having ground glass changes on their CT scans and having had no symptoms at all. So radiology really isn't particularly helpful. Now, obviously, again, the main issue is aerosol generation. So never should they have on a ward, should they have any nebulizers. And again, in terms of clinical, if you're not entirely sure whether it's COVID or not, they're never going to have a bronchoscopy. It's just not relevant. And as I said, it is pretty much supportive care. It is purely oxygen and maybe fluids if they're dehydrated. The key with COVID, and I've been a doctor for almost 20 years now. I've never seen anything that can get you walking into the department and in intensive care within 3 hours. I mean, the speed of deterioration with COVID is phenomenal. And I think the key take-home message early doors is that if they have an oxygen requirement and their oxygen requirement is even slightly going up, they are the patients that you get the CCOT team involved in early doors, because A, we now have a hugely increased ITU capacity, and B, these are the people that they can actually do something with an ITU. But certainly for the first few days we were doing it, or first few weeks we were doing it, people's oxygen requirements were going from 2 to 4 litres, and we were kind of just monitoring. But now I again, hindsight, they're the patients actually, the minute they start going up and their SATs start dropping, even incrementally, very small amounts, get ITU involved, because again, CPAP and intubation, they can be intubated and they can go from needing 4 litres to being intubated or to arresting within a matter of minutes, to be honest. It's quite terrifying. The other issue as well is the issue of anticoagulation. Now, obviously, all patients who come into hospital should be anticoagulated in prophylactic doses. And with COVID, we're now realizing that a lot of certainly the sudden deaths from COVID, and certainly a lot of the profound hypoxia without the hypoxia without the shortness of breath may be related to more microemboli. And certainly a study came out from the Brompton last month that looked at the patients on ECMO, and they could clearly see that there were so many, their lungs were filled with microemboli. And actually, I think in terms of what management of COVID potentially next time round, I would clarify with your centre what your anticoagulation policy is early doors. Again, there is no standard, and just when I was writing this, I was just trying to clarify whether the George's policy was the same as Chelsea Westminster's policy, whatever, and everyone seems to have different policies. Our policy at the moment is that everyone comes in, they get prophylactic and anticoagulation with COVID, and then if they start getting unwell, they go up to treatment dose. And then some places, if they've had COVID, they put them on treatment dose for like 10 days after discharge as well. There is no clear policy. The British Society of Hematology haven't given a clear policy either, so it is very much centre-based. And what we are seeing quite a lot of is the long-term sequelae of COVID. If somebody is presenting, a few weeks down the line with chest pain, it could very easily be a PE. It could very, very easily be pericarditis. Pericarditis is one of the things that actually, from a day-to-day point of view, we're seeing a lot. And actually, we're in the process of setting up long-term COVID outpatient clinics, because the chronic fatigue and the cardiology sequelae from COVID are quite significant and quite they make a massive impact on people's quality of lives. In terms of the kind of things that were postulated in the media, the ACE inhibitors and the ARBs, the evidence is poor. I know everyone was told to stop their ACE inhibitors and then restart them. Basically, don't change it unless there's a really clear reason, hypotension or renal failure or whatever. But don't stop them on account of COVID. And again, in terms of your patients on steroids, obviously that's going to be quite a lot of our patients. Biological agents or immunosuppressive agents, there's no clear answer. And I think that's again, another take-home message with COVID. There's no right or wrong answer, that nobody has the definitive answer to everything. The recovery trial is the one that most people have heard quite a lot about, and that has it's over 12,000 patients all over the UK. And when it initially started, probably about 2 or 3 weeks into COVID, There were multiple arms, so standard of care being oxygen and fluids and antibiotics if required. And the other arms were the low-dose Dex arm, which we now know is very effective in certain groups of patients, azithromycin, convalescent plasma, and hydroxychloroquine, and then the HIV drugs. Now, hydroxychloroquine was stopped early with limited benefit, as well as the lopinavir and ritonavir, but the low-dose Dex arm was the one that actually showed the most efficacy. But that again was in a particular patient cohort. So doses being 6 milligrams a day for 10 days or until discharge, whichever is the soonest. And this is only beneficial in patients who are either on oxygen or needing ventilation. And there has been a significant reduction in the 28-day mortality overall between either the oxygen or ventilated patients. It's a 17% relative reduction in mortality. The ventilated patients, or the ones on ECMO, have a 36% relative reduction in their 28-day mortality, and the patients on the ward who do require oxygen have an 18% reduction. However, looking at the again, patient selection is key, because it's the patients who don't require oxygen but were given steroids anyway. Actually, there was a trend towards higher mortality, so it's not a blanket prescribed steroids for anybody who comes in with COVID. Remdesivir, now, as an oncologist or even somebody running the wards during COVID, you'll never be asked to prescribe this, but there is evidence to say that there is some clinical benefit, and it has been approved and is being used in many hospitals. We know it shows some reduction in time to recovery, but whether it shows any change in mortality is questionable and is still under investigation. Now, kind of instinct would tell us that, COVID is going to be more serious in patients with malignancy, and certainly the evidence demonstrates that. But it is very specific to certain malignancies. So hematological malignancies and lung cancers have worse outcomes and are more significantly affected by COVID. Now, hematological malignancies and lung malignancies are probably the ones you would expect. Hematological malignancies being, obviously they're immunosuppressed, and their bone marrow is often pretty hammered at the best of times. So they are going to be more susceptible. And again, lung cancers, whether it is purely because of the biology of the lung cancer, or whether it's most of these patients are smokers, will probably have heart disease, and they're the risk factors for, increased risk factors for COVID anyway. We don't know. Looking at a meta-analysis of 32 studies worldwide, and that was about 40,000 patients with 1,500 with cancer. Yes, the all-cause mortality was higher in patients in those with cancer, and yes, their need for ITU admission was higher as well. And looking in the UK, again, that was all borne out as well. But the key predictor of whether you were going to survive COVID as a cancer patient was whether you were over 50 or not. So the patients over 50 had were more likely to die. And again, that was borne out whether it was COVID or not, to be honest, or whether it was cancer or not, to be honest. But looking at the kind of digging down into the cancer patients in the UK, if you've been diagnosed with a hematological malignancy in the last year, you had a 4-fold increased risk of death, which is fairly staggering. Anybody with a non-hematological malignancy had a 1.83-fold increase of death compared to the general population. And actually, the majority of these patients, when they say increased risk of death, it was mainly lung cancers. Now, in terms of, this has been the biggest surprise for us in terms of the effect of recent cancer treatment on COVID severity. The initial data that was coming out of Wuhan in February, March time, and the data that we were basing our decisions on was saying that actually, if you'd had recent chemotherapy in the previous month, you were 4 times more likely to die. And actually, totally, that was something that we all assumed. However, interestingly, when the data was actually looked at properly from Wuhan, it was very inconsistent, and it was, it was essentially very half-patched. There wasn't proper data at all, and sadly, that was initially what we had been basing our decision making on. In the last month or so, there has been a publication. I think it was in the Lancet. I can't actually remember where it was. It was nearly 1,000 patients looked at from Spain and the US and Canada. And actually, there wasn't any increased mortality related to having chemotherapy in the previous 4 weeks. This doesn't look at immunotherapy, it was purely chemotherapy, but it was there was no increased mortality. And actually what was increased with the mortality were the independent factors that would have increased your mortality anyway, being older, male, smoker, etc. And again, looking specifically in the UK at the COVID and cancer monitoring register, again, the mortality rate's about 28%, which is probably in keeping with, you know, the general population of hospitalized patients. But there, again, recent chemotherapy does not impact on mortality. And obviously now looking back with knowing this, and again, it's still not clear. You're talking about still small numbers of patients, but we obviously changed our NICE, and NHS England gave us very clear guidelines based on what we should and shouldn't be doing in terms of giving chemotherapy. At St. George's, we were quite lucky in the fact that we were able to move our chemotherapy unit out of the main hospital and into a building off-site, or not, it was on-site, but slightly away from the hospital. George's is, if anyone's been there, is quite an old building and has lots of random outhouses, and we were able to move the chemo unit out there. Hence, the patients didn't have to come into the hospital. Everyone was swabbed before they went in and out of this unit. So it was a green or a clean zone. So actually, in terms of stopping chemotherapies, we were very cosseted in, we didn't give chemotherapy kind of third line colorectal cancer type Lonsurf, but for most things we were actually able to keep going. And I'm very aware that that wasn't the same in the UK as a whole, and even within London as a whole. Now, whether we'd have made our decisions differently based on the information that we know now from the Cancer Consortium Register, probably not, I suppose, because the numbers are still small. But even looking at the number of our patients that were admitted or died of COVID who had been on chemotherapy, you're talking about less than a handful. And that was the most surprising thing about COVID, that we were expecting our wards to be essentially overrun with cancer patients on treatment being diagnosed, and that wasn't the case in any way. I think, yeah, the number of patients that certainly died on active chemotherapy, sadly both on adjuvant chemotherapy, there was 3, I think, in total. Now, in terms of COVID and chemotherapy at the moment, what happens? Most, again, not all centres are doing the same thing, but certainly what we do at George's is that all patients are required to have a COVID swab 48 hours before their chemotherapy. You get the results within 12 hours, and they have to shield between the COVID swab and before they have their chemo. If the patient does test positive for COVID and is systemically well, they can be managed at home. Now, in terms of restarting chemotherapy, it's again a bit of a point up for discussion. Certainly, we wouldn't start chemotherapy for a minimum of 2 weeks, and at least they have 1 or 2 COVID swab negative. The ASCO guidelines have come out and said, look, they need at least 2 weeks and 2 negative swabs at least 3 days apart, or 2 days apart. But the NICE guidelines are considerably less stringent and basically just said defer if possible, and you need at least 1 negative swab. Now, I have to say, again, speaking to other oncologists in London, I think most places are deferring for 2 weeks and need at least 1 to 2 negative swabs before they'd go back in with chemotherapy. The difficulty at the moment in terms of, for our patients, is the neutropenic sepsis patients, and I suppose getting the mindset of A&E and the general medics that we did go through 3 months of anybody who came in with a temperature had COVID, and I think you almost forgot that anybody else could potentially have anything else. And it's trying to get people back into the mindset that this could be neutropenic sepsis rather than COVID. The issues that we're having, and certainly that I have experienced on call, is patients coming in with flat counts, neutrophils of 0, lymphocytes are flat, and they have a temperature, a few days after chemotherapy. And they're automatically, despite flat counts and temperature, they're automatically put on a COVID ward. And, it just fills you with dread, because if they don't have COVID going in there, they'll probably have it coming out. So the way we're getting around it at the moment, and it's far from ideal, is that patients are put in a side room on a query COVID ward or an amber ward, and so not the COVID positive, but a possible COVID ward, until the swab results are available. The swabs are fast tracked, and then they're treated for neutropenic sepsis anyway. But again, because all of these patients are generally being admitted under the medics, you do have to prompt the medics to make sure that they've had their antibiotics, they've had their fluids, because since COVID is treated so symptomatically, they're not great at remembering to treat neutropenic sepsis, and I think that's something that we have become very aware of. And again, as soon as the COVID swab comes back negative, we ensure that the bed manager knows early doors that this is a potential issue, so they can identify a bed on a COVID negative ward. Now, NHS England back in March gave a clinical guide to how you manage our cancer patients needing acute treatment. Now, I didn't realise there were some med-oncs on this call as well, so I've done a more radiotherapy-based slant, but actually both chemo and both med-onc and clin-onc patients were assigned a treatment priority based on their treatment intent and their tumour biology, and certainly for radiotherapy or category 1 patients, your priority level 1s were patients who were currently being treated with radical chemo-rad with curative intent or external beam radiotherapy, and the external beam was already underway, or in patients who hadn't yet started their radiotherapy, but the clinical need was as such that the treatment had to continue. And essentially, if you were level 1, you were allowed, or it was certainly suggested that you would continue the treatment as planned within the possibility of what you could offer within your centre or your cancer hub. And then it went down again, level 2 being, palliative radiotherapy in people with cord comp, level 3 being patients who needed radiotherapy as their first definitive treatment, or where there was residual disease following surgery in tumours with an aggressive biology. And then level 4 and 5 being more palliative, level 4 being palliative radiotherapy in patients that they could potentially be managed in other ways, although maybe not optimally in other ways, but there was another option. And again, level 5 in patients who really, had a complete resection of disease, had very little risk of recurrence. And chemotherapy and the chemotherapy patients were assigned similar levels. And then it was a kind of decision in-house about who you were going to treat and what level you assigned them. Now, again, this wasn't clear across London, and certainly everyone was doing slightly different things. And I am aware that we were in a slightly lucky position at George's that we were able to continue giving majority of our patients. There was very few patients we actually had to have the conversation with that we were stopping treatment. It was, again, very minimal numbers. Now, in terms of radiotherapy, what has happened, and I don't know, I'll defer to my clin-onc colleagues about what's happening now in terms of radiotherapy, but certainly at the time of COVID and what may well happen again with round 2, is that, a hyperfractionated schedule should be used in as best possible. And in terms of adjuvant, say, breast radiotherapy patients, you could offer, to omit the radiotherapy in patients with low risk breast cancer. And actually, in a lot of the time, in terms of for the brachytherapy and everything, it wasn't so much the radiotherapy was an issue, it was the anaesthetic capacity, because obviously the anaesthetists were all co-opted to ITU, and the possibility of having any anaesthetics was minimal. Now, just very briefly at the end, I'll touch on immunotherapy complications. Most of the cancer registry with COVID and everything hasn't included immunotherapy, or certainly hasn't included in any great numbers. As we know, with immunotherapy, the side effects are many and varied, but immunotherapy is now standard of care for a considerable number of our cancers, mainly being obviously metastatic melanoma, but now an increasing number of indications as well. And the immunotherapy, so the CTLA-4 inhibitors like ipilimumab, and the PD-L1 and PD-1 inhibitors like durvalumab, pembro and nivo, there's very common to have adverse events. Ipilimumab, pretty much, over half your patients will develop toxicities. Half of them will, more than half of them will be, grade 1 or grade 2, where you can continue having your treatment. But there are, maybe 1 in 5 that will have very severe toxicities that will require a hospital admission, cessation of treatment, and potentially intensive care. The toxicities from the PD-1, PD-L1 inhibitors are much less common. Ipilimumab essentially is your dirtiest drug, and that is the one that causes the most problems from a kind of admission point of view. The combination of both, so ipi-nivo, say particularly for melanoma, you are going to get grade 3 side effects, so enough to stop your treatment for at least a while in over half of your patients. And I think the key to remember is that adverse events can happen at any point during the treatment trajectory and afterwards. So in terms of treatment, it can happen We know we've had patients 3-4 years after finishing Nevo coming in with being pan-hypopit or having liver issues. So if they have ever had immunotherapy, it is something to consider. The common ones, I mean, I'm sure you guys all know this already, but the common ones being the skin rash is the commonest, and majority of patients will get some kind of itching or rash in some way. The ones that cause the most problems realistically are the gastrointestinal side effects and the hepatitis. The diarrhea and colitis is the one that we see the most, mainly because we treat a lot of melanoma at George's, and a lot of our patients are on Ipi-Nevo. Hepatitis, pancreatitis, the pan-hypopits are quite, when people come in very tired post immunotherapy, it's not unreasonable to think it's as a result of their treatment, but checking their endocrine profile is very helpful. Hypo and hyperthyroidism, pneumonitis, we've actually seen quite a few, probably about maybe 5 or 6 myasthenia gravis or secondary to immuno, as well as encephalitis and aseptic meningitis. Ocular side effects are not actually as rare as you would think. So a uveitis is relatively common. I'd say that probably less than 10%. And again, a myocarditis or a pericarditis from cardiac side effects. And the onset is to be honest, you can pretty much predict when things are going to start causing problems. The rash always being the first one within a few weeks of starting treatment. And then your liver toxicity will kick in about 4 or 5 weeks after starting anything. Again, it can happen at any point, but often you see that's the time they develop a transaminitis. And the diarrhea, again, not necessarily the most difficult to treat, but the most problematic and the biggest cause of stopping therapy, happens about a month to 6 weeks after starting treatment. And then it essentially just continues and continues unless you either stop your treatment or change the dose. And your grade 3, grade 4 side effects generally happen at the 6 to 8 weeks and require admission. Now, the management is very much dependent on the adverse event grade. So grade 1 and grade 2, you can generally continue the treatment, depending obviously on how much it's impacting on the patient. But you can also continue your immunotherapy at the same time. Generally with grade 3 or 4, it's sensible to stop, and then you start your methylpred. So things haven't changed very much in terms of immunotherapy. It's a milligram per kilogram of methylpred with PPI cover. If you are going to see an improvement, whether this is diarrhea or hepatitis, you generally will see an improvement within a few days. I would say we are now, again, better at realizing that we are not all things to all men, and that we do need to get the gastroenterologists and the hepatologists in early doors, because we were notoriously bad at thinking we could manage everything ourselves. And actually, since we've started getting them in, surprisingly, they're very good at managing diarrhea. Then if there is no improvement, you'd increase your methylpred to 2 milligrams per kilogram. And again, if there's no improvement in that, looking at other biologics is not unreasonable again, but again, it has to be a multidisciplinary approach. And also if you're struggling as a registrar, certainly you will never be expected to manage immunotherapy side effects on your own. And the most important thing to remember is your consultant probably hasn't got a huge amount of experience of this either. So don't be afraid to ask questions. So that is my whistle-stop tour around COVID, immunotherapy, and a whole lot in between.
Thank you.